Hi, my name is Jason Spedden. Today is March the 20th of 2022. Today I will be answering the case question number 2 and case question number 4. So in regards to explaining glycogen and how it's used normally during exercise, so as you know, glucose is the major fuel our bodies use for most tissues. When your blood glucose levels are sufficiently high, and this is to allow excess glucose to be stored, something called glycogenesis, which is the synthesis of glycogen, is stimulated by insulin. So your body takes the glucose, saves it pretty much for a rainy day in a sense. This glycogen is a major store of carbohydrates in the body, which usually occurs in the liver, the muscle, and a slight bit in the brain as well. When your glucose levels start to drop, your body will use that stored glycogen to turn into glucose, so your body will have a steady supply of energy coming in. Now, during exercise, something called a GLUT4 transporter, which is in your body, will move into the muscle fibers, allowing glucose into the cell to be used as fuel. Your body will also simultaneously break down any glycogen storage that you have as increases in response to changes in the concentration of metabolites inside the cell will occur. The glucose molecules from the blood and then those released from glycogen in the muscle, they are oxidized. Now this is to produce something that is called adenosine triphosphate, which is also known as ATP. This is the energy source for the body, and that is required to sustain muscle contractions. So now, a deficiency in muscle glycogen phosphorylase, which you have, this is also known as McArdle's disease. Most patients will tend to experience the bulk of their symptoms during and after moderate to intense anaerobic exercise lasting longer than just a few minutes. You'll have anaerobic and aerobic, which I'll explain to you in a moment. Most patients complain of muscle pain and cramping. Now, this is due to your body lacking that glycogen phosphorylase enzyme, which is responsible for the actual breakdown of that glycogen. And this will lead to a buildup of glycogen in your muscles. Now, this buildup is what's going to cause that pain in your muscles and the weakness based on it's going to be causing muscle cell damage. This will happen especially in the larger muscles, such as your thighs. Now, some of this pain can be lasting or permanent, so it all just depends on how much you're trying to exert. But under normal conditions, glycogen phosphorylase, it will convert glycogen to something that is called glucose 1-phosphate via a phosphorylated cleavage of the 1 to 4 linkages in that glycogen. So once that happens, glucose 1-phosphate is then phosphorylated, in which what that is an addition of what's called a phosphate group into glucose 6-phosphate, where it is then dephosphorylated, which is the removal of a phosphate group, and that will be turned into glucose. That glucose is used for ATP synthesis via cellular respiration. Now, some of this pain can be lasting or permanent, but studies show that things like moderate aerobic, which is different than anaerobic exercise, is beneficial to those with McArdle's disease. There's something actually known as the second wind phenomenon. So this second wind phenomenon is something that is defined as a period of less painful and more effective exercise associated with a decrease in heart rate after the initial period of cramping or weakness. So as you start walking and you go along your little walks, you'll actually, after the first about 8 to 10 minutes after beginning that aerobic exercise, you'll start to get what's called that second wind and feel a lot better, and it'll be a lot easier. So regular physical exercise has been shown to actually play a key role in delaying progressive muscle wasting, weakness, and frailty in later life of people that are affected with McArdle's disease. So your long walks with friends are actually going to be encouraged, as long as you're not exerting too much. Now, anywhere between 3 to 4 hours after eating, your body will deplete its free glucose and need to create some more. So glycogen is also stored in your liver as well as your muscle, and the breakdown of glycogen in your liver is similar to that in your muscles. The major difference being the breakdown of glycogen into glucose in your muscle is actually only for the muscle. something called glycogenolysis in the muscle does not distribute that glucose to the rest of the body and is only used in the muscle. Now, while you sleep, glycogenolysis in the liver will release glucose into your bloodstream to be used by the rest of your body. So you will not need to interrupt your sleep to ingest any type of carbohydrates, as your body will be doing this from the liver. Now, when it comes to carbohydrate ingestion, eating or drinking some type of sugary drink anywhere from 15 to 30 minutes before a certain type of exercise, like your walks, that has been shown to decrease the common symptoms of McArdle's disease. Now, when it comes to the lactic buildup that you're asking about in your muscle, no excessive lactate will be produced in your actual muscle cell. Your body produces lactate via anaerobic respiration. Glucose goes through something called glycolysis, and it converts something called pyruvate when oxygen is absent. Now, pyruvate then gets converted into lactate by lactate dehydrogenase. Now, people who suffer from McArdle's disease do not produce lactate during exercise due to glycogen breakdown being completely blocked from missing that phosphorylase enzyme, whereas oxidation of glucose outside of the muscle cell is still capable. So my answer for case 4, we'll start that now. Now, upon assessing the information given, it is clear that this infant is suffering from a glycogen storage disease type 1, otherwise known as von Gierke's disease. The patient presents with hepatomegaly, or an enlarged liver. Von Gierke's disease is characterized by a buildup of excess glycogen and fat in the liver and kidneys, which will lead to an enlarged liver and enlarged kidneys as well. So this glycogen buildup is due to a deficiency in the enzyme glucose 6-phosphate, which is responsible for cleaving glycogen to produce glucose normally in a healthy patient. There are 2 different subtypes of the deficiency that are labeled as GSD1A and GSD1B. In GSD1A, the enzyme activity is deficient in itself. But with GSD1B, you have normal glucose 6-phosphate enzyme activity, but have a deficiency of the transporter enzyme. And that transporter enzyme is glucose 6-phosphate translocase. The primary symptom of GSD in infancy is low blood sugar level or hypoglycemia, which this patient has shown. Now, symptoms of GSD usually begin at around 2 to 4 months of age, which our patient actually falls directly into that range. So now this enzyme deficiency also results in some other metabolite imbalances such as lactates, uric acid, lipids, and triglycerides as well. Now, the breakdown of glycogen via the glycogenolysis is initiated when glucose levels are low, especially in the fasted state. Now, the patient's blood glucose levels increase after breastfeeding. Now, this is going to be due to the glucose-rich breast milk. Now, but during fasting, the patient cannot sustain normal blood glucose levels due to their inability to break down the glycogen. But upon receiving epinephrine, we see no rise in blood glucose, but a rise in blood lactate. Now, epinephrine induces hyperlactatemia, which epinephrine stimulates the release of lactate from the skeletal muscles through stimulation of the sodium and potassium and ATPase for oxidation purposes, or gluconeogenesis from the Cori cycle. Now, when it comes to the other answers, we can actually eliminate the hereditary fructose intolerance, from the conversation due to the infant only having fed breast milk for the duration of her life thus far, where the primary sugar in breast milk is going to be lactose. While fructose can still be present due to the mother's diet, we would see a decreased level of phosphate as well, which was not seen in this case, as well as elevated fructose in the labs, which was also not present. Now, in regards to the galactosemia, we can rule that one out as well, based upon the lab results as well. not indicating a high level of galactose. Now, with galactosemia, these symptoms also tend to appear a few days after birth, which in this case did not happen, as the child is only 2 months old. Now, for the other answer of glucose 6-phosphate dehydrogenase deficiency, we can rule that one out due to, again, the lab test not showing a decrease in this enzyme, as well as glucose 6-phosphate dehydrogenase deficiency being an X-linked recessive disorder seen mostly in males. This patient being a female, and they are typically just carriers.